So good morning, everyone. I'm Provencio. I'm the current president of IASLC until this late afternoon, and then presidency will be taken over by Dr. Kai-Kun Zhou from Shanghai, China. So welcome to our third press briefing of the conference and the second on the Presidential Symposium research. Abstracts selected for the Presidential Symposium status are among the highest rated and scored abstracts for more than 1,800 submissions we received. I'm honored to introduce a star-studded lineup of researchers this morning. I'd like to call particular attention to our IASLC patient research advocate, Shani Shiloh, who will be providing her unique patient perspective on this morning's research. Please hold all your questions until the end of the briefing. So we would like to start now, and our first presentation comes from Dr. John Varlotto from the Marshall University in West Virginia. Dr. Varlotto is currently the Chief of Radiation Oncology and Professor of Oncology at Marshall University. He also serves on the Thoracic Oncology Committee for ECOG-ACRN and as President of the Cable County Medical Society. This morning, he will share results from the phase 3 trial of Concurrent and Consolidative Durvalumab versus Consolidation Durvalumab alone for unresectable stage 3 non-small cell lung cancer. So welcome, Dr. Varlotto. You have approximately 4 to 5 minutes. Yeah, I think you should come over here. You do it? Or? Yeah. Just probably easy for you.
You don't want me to re-give the talk to you?
4 to 5 minutes on main points.
Okay.
Yeah, 4 to 5 minutes. That's a bit shorter.
All right, so I'll just... Hello, it was a great pleasure to have our abstract from the ECOG-ACRN Thoracic Oncology Committee to be accepted to the IASLC for their presidential symposium. Ours trial was a phase 3 randomized trial that looked at improving outcomes for stage 3 unresectable non-small cell lung cancer in the United States. As you know, the Pacific trial has been our standard of care, and it's been FDA approved since 2018, so that has stood uncontested as the standard of care for over 7 years, which is almost an eternity in lung cancer research today. Our trial looked at improving that by giving concurrent chemotherapy and radiation therapy with Durvalumab was our test question. What does this add in terms of overall survival as our main primary endpoint? We had 2 steps of our study. It was concurrent chemo radiation plus or minus Durvalumab. Afterwards, we consolidated with Durvalumab for 1 year in both arms. If there was no progression, no pneumonitis, and all toxicities resolved to grade 2 or less within 45 days. What we noted was that the overall survival is our main primary endpoint did not differ between arms. The curves are superimposable. The hazard ratio was near 1. We also noted that when we gave concurrent Durvalumab during the course of chemoradiation therapy, the progression-free survival curves were actually the same. Very interestingly, there was no increase in toxicity, whether we looked at cardiac, whether we looked at pulmonary, whether we looked at grade 5 toxicities. There is no statistically significant differences between the arms. We also looked at overall response rates as part of our secondary analysis with step 1 with concurrent chemo radiation plus or minus Durvalumab. They were around 50% and not statistically significantly different. When we looked at response rates, including step 2, which was consolidation, overall response rates were approximately 70% between arms. We defined local recurrence 2 different ways. There is some confusion about what actually is a local recurrence. We defined it as being one way within the ipsilateral lung in the N1 to N3 nodes. We saw a 22 to 24% recurrence rate locally. When we defined it, it was being within the radiation therapy field, which was really surprising. There was only a 7% recurrence rate, which is roughly the same between the arms. So overall, We did not see any benefit in terms of our primary endpoint. We did not show that giving concomitant chemo, radiation, and immunotherapy was superior to the Pacific regimen, which was our control arm. There was no difference in progression-free survival, recurrence rates, response rates, or toxicity. We think that there's room to grow. We'll be just starting to look at our laboratory analysis, looking at NGS, looking at TMB, looking at radiation parameters, looking at clonal hematopoiesis and its effects on toxicity, as well as efficacy of treatment. So we're very excited to move forward with this study, and it was a great pleasure to present at the Presidential Symposium. I am honored and flattered to have been here with such a great investigative group and with such other great studies. Thank you.
Thank you, Dr. Varlotto. Please hold your questions until the end of this meeting. Our second presentation comes from our host country, Spain, presented by Dr. Mariano Provencio, and he will present data on adjuvant chemotherapy versus CT-immunotherapy for R0, stage 1B till 3A non-small cell lung cancer patients. This is the NADIM adjuvant trial. It's a randomized phase 3 trial. Dr. Provencio is chief of the medical oncology department at the Hospital Universitario Puerta de Hierro, I almost said Maradona, but it's Majadahonda? Majadahonda, okay, apologies. And full professor of medical oncology at the Faculty of Medicine of the Universitat Autónoma de Madrid. Dr. Provencio, thank you for joining us.
Están las slides, ¿no? Sí, póngamelas. Good morning, everyone. Thank you for the invitation to be here. I tried to analyze the trial, very simple, not with too high numbers. You know, the trial is designed in patients, completely resected patients who have a lot of risks of relapse. And the current treatment of these patients is currently chemotherapy, and then in some cases, according to the PD-L1 expression, immunotherapy or not, according to the different regulatory aspect. And then we designed this study with the combination with chemo and immunotherapy. This is the first time we're using chemo plus immunotherapy at the same time in adjuvant setting after surgery. It was based in our experience in perioperative treatments with chemo plus immunotherapy. This is the design. Patients with high risk of relapse. The usually treatment in this patient, the standard treatment in this patient is chemotherapy and then immunotherapy in some cases. The randomization was between chemo plus immunotherapy 6 months, the rest of the study length 12 months, versus only chemotherapy. The primary endpoint was disease-free survival, and we have other exploratory endpoints I comment later. This is a statistical analysis. Finally, we recruited 206 patients in 2 arms, 103 in control arm, 103 in the experimental arm. These are the baseline characteristics, very related to the normal population treated in this case. And you can see here more than 15% were over 70 years old. Also, the high percentage of patients with comorbidity, important comorbidity, more than 96% had shown important comorbidity. And the rest of parameters are quite similar in the both arms. The NGS was performed only in 2%, was not mandatory, and 7% in the control arm. The results. This is the graphical representation of the results, very graphic representation. And the French expression is this is almost twice relapses in control group, 20 versus 38%. The DFS, the primary endpoint was DFS. And you can see here the DFS, the median DFS was not reached, but the hazard ratio was 0.65, was not significant. This is an interim analysis. We need more maturity of the data. The maturity of the data is around 50% of the data we designed the trial. But importantly, the first quartile DFS was 13 months versus 18 months in the first quartile of control group. All the subgroup were in favor with chemo plus immunotherapy, the experimental group, especially in these patients who had completed the treatment. We performed two sensitivity analyses. One is using the landmark analysis from the 90 days after surgery. Other analysis is from the last cycle of chemotherapy. These analyses were designed to compare with other clinical trials using adjuvant immunotherapy, because this trial using patients after this time. And as you can see here, the hazard ratio was in the landmark analysis after 90 days surgery, hazard ratio 0.6, significantly, p-value 0.04, and the sensitivity analysis using the data from the last cycle of chemotherapy. This is the point, the other clinical trials in immunotherapy, for example, in POWER or in POWER 10 or KEYNOTE, the hazard ratio was 0.55, also significant. The DFS cancer specific was also positive, hazard ratio 0.54, p-value 0.02. And this is an immature results, because we have to consolidate the results. This is we have 15% of the maturity of the data, but we think we have a meaningful reduction of the relapse. There are a serious signal of the activity. Analysis of the cancer-specific DFS was clearly significant. And also, I want to remark the inclusion of all patients in the real-world evidence that this patient exists, and we have to treat the same way. The tolerability, the safety is consistent with the previous. We know this treatment in other situations. And also, we have to have more information about the useful or not the minimal residual disease, and we maintain the follow-up. Thank you very much.
Thank you, Mariano, for this excellent study. Dr. B presented the abstract phase 3 trial on hypofractionated versus conventional fractionated radiotherapy with concurrent chemotherapy for limited stage small cell lung cancer. But she has not arrived yet, so we put her at the end and we move on to the next extract. So lung cancer surgery, the next one, is an area that always piques my interest, as I'm a thoracic surgeon, so you may understand that. So I was excited to see our next abstract, survival outcome of VATS, so video-assisted thoracic surgery, compared to open lobectomy for lung cancer, an individual patient data meta-analysis of randomized trials. Presented by Dr. Jacie Jiaqi from the Royal Brompton Hospital, United Kingdom. Dr. Lowe is a cardiothoracic surgery specialist trainee under the Pan-London Cardiothoracic Surgery Training Program in the UK. She focuses on early-stage non-small cell lung cancer, minimal invasive thoracic surgery, ERA, so enhanced recovery after surgery, patient-reported outcome measures, the PROMs, in surgical research, randomized controlled trials, and statistical methodologists. Thank you for joining us, Dr. Lowe, and please present your research in 4 to 5 minutes.
Good morning. It's an honor to be here on behalf of my research team and also my surgical mentor, Professor Eric Lim, is also in attendance. We are delighted to have the opportunity to present an individual patient data meta-analysis of randomized trials, which aim to determine survival outcomes of VATS compared to open lobectomy for lung cancer. So VATS lobectomy is a surgery that is performed day in and day out for early stage lung cancer. But we know that it's widely adopted based on non-cancer benefits. So this includes demonstrated benefits in areas such as reduced post-operative pain, reduced complications, shorter hospital length of stay, and also improved quality of life for patients after surgery. There is still equipoise regarding the adequacy of VATS as a surgical access. There's been no high-level randomized controlled trials to date that has been adequately powered to detect a difference in the key outcome of survival. Though there are published meta-analysis from previous from studies which are predominantly propensity match studies. Again, there is no randomized trials that have reported a statistically significant outcome difference in survival. So to address this question, we performed an individual patient data meta-analysis of all eligible randomized trials. The aim was to increase the sample size so that we can enhance our precision to detect any differences in survival between VATS and open surgery. Our study's primary outcome is overall survival, and the key secondary outcome is disease-free survival. We obtained ethical approval prior to the conduct of the study. We embarked on a comprehensive literature search, and we identified all completed randomized trials that compared VATS to open lobectomy in clinical early stage lung cancer that was conducted in this side of the millennium. Although we identified 554 unique studies, most of it was excluded due to the fact that they were not randomized study designs and also did not indicate or contain survival outcomes for analysis. This left us with 3 sufficiently high-quality randomized trials, which was Bendixson, Long, and Lim. This provided a total of 1,185 patient data, of which 586 were randomized to the VATS group and 599 to the open lobectomy arm. All our analysis was conducted on an intention-to-treat basis using a one-stage random effects Cox proportional hazard model. So when you look at our patients' baseline characteristics, they were well matched within each study. And when you move on to the post-operative data, patients remain well matched when it came to their post-surgery pathological TNN stage. We also achieved high zero of R0 resections across all 3 randomized trials. And although we see differences in the proportion of patients who received adjuvant chemotherapy within each studies, this characteristics was well balanced within each trial. Our primary outcome showed that VATS lobectomy conferred a 21% reduction in the risk of death compared to open surgery, as shown by our hazard ratio of 0.79. And when you look at the forest plot, you can see that this favorable survival effect with VATS was consistently seen across all 3 trials with no heterogeneity. And when you look at the secondary outcomes, there was no difference in the disease-free survival between VATS and open lobectomy. And our hazard ratio here is 0.91. This is a treatment effect which is consistent in the direction of overall survival, but one that was not statistically significant. We ascertained that the 20% improvement in overall survival that we see as clinically meaningful difference, and as you know, in reference to general thresholds for recommendations, use and guidelines for adjuvant chemotherapy. We also partitioned survival after lobectomy into 2 principal competing risks: non-cancer specific versus lung cancer specific outcomes. And we know that in previous studies, VATS have reported a reduction in serious adverse events and lower hospital readmission. And we take this as potential examples of factors that could improve or influence non-cancer outcomes. And certainly there has been no high-quality studies published to date that has suggested that VATS is associated with poorer lung cancer-specific survival. So in conclusion, our study, for the first time ever in history, ladies and gentlemen, provides evidence that in early-stage lung cancer, but through a seemingly simple change of our access to VATS, we can expect a 21% reduction in the overall risk of death with no evidence of compromise to disease-free survival. And I'm sure all of the thoracic surgeons in the world would agree with ourselves that should be prioritized as the preferred approach in surgically resectable lung cancer. Thank you very much. I want to thank the Bristol Trial Centre for offering their highest level of statistical expertise and integrity, the United Kingdom Thoracic Surgery Research Collaborative, our co-authors from Odense University Hospital, Denmark, and Sun Yat-sen University Cancer Center, China. And of course, I have to thank the generous participation of every patient and research member who drove the successful completion of the original trials. And my first author, Rosie Harris, was funded by NIHR UK, and I was funded by the 2023 SCTS AstraZeneca Thoracic Oncology Scholarship Award. Thank you for giving me the skill sets to be here with you today. Thank you very much.
Thank you very much, Dr. Law. Let's stay with our surgical team with the next excerpt, which is called Spreads to Air Spaces, or STAS, and Patient Outcomes in the Phase 3 JCOG 0802 trial of segmentectomy versus lobectomy in early-stage non-small cell lung cancer. It was presented by Dr. Jacie Jiaqi. Unfortunately, he had another urgent meeting, so will be replaced by a very nice lady, Mary-Beth Beasley from Mount Sinai, who will present the data. Dr. Beasley is thoracic pathologist at Mount Sinai Hospital in New York, the US, and she will present us for 4 to 5 minutes.
Yes, please. Thank you. Okay, thank you. Hi, so this is an effort by the pathology panel of the IASLC, on which Dr. Yatabe and I both participate, along with Dr. Ming Zhao, who's also in the audience, and we were very honored that our study was selected for the presidential plenary session this year. So I'll start off just by saying, what is STAS before we get into the analysis and why it was important that we undertook this. So this was nicely illustrated by the discussant. However, we did not have time to condense this into our study. So spread of tumor through air spaces is a rather unique phenomenon of invasion that occurs in lung carcinoma, where you have balls or single cells of tumor extending beyond the edge of the main tumor within the specimen. And this has been associated with poor prognosis in multiple studies. It's particularly been associated with poor prognosis in sublobar resections, such as segmentectomies or wedge resections, and not quite so much in lobectomy. So there was somewhat of a suggestion that perhaps if STAS was present, then a patient potentially needed a lobectomy. A few studies have tried to look at that. However, they did have various limitations. So what we wanted to try to do was look at the impact of STAS in a coordinated group of lobar versus sublobar resection cases. So the JCOG 0802 study presented quite an opportunity to do just that. So looking at our cases, so we started off, there were 1,106 cases in the original cohort. We were able to retrieve pathology from 646, and ultimately 640 were included in the study. And these were equally balanced between lobectomy and segmentectomy, and I think it's also important to note that the cases that we were retrieved, even though they were a subset of the study, were reflective of the JCOG study set as a whole, and there was also a good balance between the lobectomy and segmentectomy subsets in regard to types of tumors. There were no discrepancies or unequal balancing between the two groups. So our points with this study were to try to evaluate various aspects of STAS in the surgical specimens, whether it was associated with relapse-free survival or increased overall survival in both the overall segments, overall study, or in either the lobectomy or segmentectomy group when analyzed separately. We also wanted to look at the local recurrence rate as well as distant recurrence rate, and we also wanted to look at a subset of the non-mucinous adenocarcinomas, as I'll get to, in regard to whether STAS versus grade was more predictive of survival. So in regard to our study, this was the overall cohort in regard to recurrence-free and overall survival. You can see that the STAS-positive patients were associated with a significant outcome difference in both recurrence and overall survival. You can see that the two graphs look virtually identical here, and importantly, it's interesting to note that at the 5-year point in the overall survival, the lines are essentially parallel and only separate after that. In regard to multivariate analysis, again, recurrence and overall survival, STAS remains significant in regard to the overall cohort as independent prognostic factors. Looking at the subgrouping of segmentectomy versus lobe, you can see that both there was a higher frequency of local and distant recurrence in tumors with STAS, regardless of subtype, although distant recurrence was only significant in the segmentectomy group. Local recurrence was similar in both arms. And then similarly, survival in the lobectomy versus segmentectomy groups also demonstrated similar findings, although ultimately the recurrence-free survival was similar in both arms, with only shorter overall survival in the lobectomy group. And then in regard to non-mucinous adenocarcinomas, while you can see STAS in a variety of types of lung cancer, it is predominantly found in non-mucinous adenocarcinomas. So we wanted to look at the impact of that in particular as well. Of our overall group, there were 487 cases. And as you can see in the bottom corner, STAS was primarily associated with tumors with grade 3 histology. We currently only have an accepted grading system for non-mucinous adenocarcinomas, so that's why we could only analyze grade in regard to this subset. And as has been shown previously, there's a very strong correlation with STAS and high-grade tumor histology. So overall, in the overall pathology study cohort, the presence of STAS was identified as an independent prognostic factor for both recurrence-free survival and overall survival. We did have a higher frequency of local and distant recurrence in tumors with STAS. In regard to looking at surgical subtypes, lobe versus segment, the STAS-positive tumors had higher frequencies of local recurrence in both subgroups, but distant recurrence only in the segmentectomy group. The presence of STAS was confirmed to have shorter recurrence-free survival in both subsets, but only shorter overall survival in the lobectomy subset. And then in regard to non-mucinous adenocarcinomas, with a histologic grade comparison, grade 3 was confirmed as a poor prognostic prognostic factor for recurrence-free survival and overall survival. It was strongly associated with STAS, and then one thing that I didn't point out in the prior graph is when you looked at the multivariate analysis, while STAS was a poor prognostic indicator for recurrence-free survival, only the grade 3 histology was important for overall survival. So ultimately, our conclusion is that while STAS does have a negative impact on prognosis, the presence of STAS did not negate the original conclusions of the JCOG 0802 study, which showed that segmentectomy was non-inferior to lobectomy in regard to outcomes in patients with stage 1A non-small cell lung cancer. Thank you.
Thank you, Dr. Beasley. Our next abstract looks at the intersection of age and lung cancer screening. Dr. Patrick Goodley from the Manchester University NIH Foundation Trust in the UK has joined us to share his findings from the study comparing 74 versus 80 as the upper age limit for lung cancer screening, a multi-center cohort study. Dr. Goodley is a respiratory physician completing specialty training in Manchester, having graduated from Cambridge and undertaken junior training in London. He is currently a clinical research fellow, having completed a PhD at the University of Manchester under the supervision of Professor Phil Crosby. Please, Dr. Goodley.
Thank you. Thanks for joining me today, and thanks for the introduction. I'm going to talk to you today, yes, about a multi-center study that we did with Leeds, looking at what the upper age limit for lung cancer screening is. So in the UK at the moment and other countries, we're expanding access to CT scan screening, which is targeted at high-risk people up to different age limits, which I'll talk about. So, and in the UK at the moment, the median age for lung cancer diagnosis is around 75, so half of lung cancer cases are diagnosed after that age. And the evidence base for lung cancer screening, which strongly shows that there's lung cancer mortality reduction between 20 and 25%, only went up to people aged 74. So we have lack of evidence after that age as for how well screening works. And there is an evolution of the balance of risks and benefits as people get older, and it's important to understand how screening actually works, how those risks and benefits balance out as people get older. So the US has been screening to the age of 80 for over a decade now, but we're still short of evidence to see how it works. So what we wanted to do was provide some evidence to fill that gap, see if an older group, 75 to 80, benefits from screening as much as the younger, better studied group, 55 to 74, and if we can pick out people who will benefit the most. So we looked at two screening cohorts from the UK, the only two to have gone up to the age of 80. The Yorkshire Lung Screening Trial and Manchester Lung Health Check Programme. And particularly the Manchester programme targeted high-risk deprived communities where lung cancer burden is really high. We wanted to see how well people survive from the point of diagnosis after detecting their cancer through screening. And we compared those two age groups of interest, 55, 74, 75 and 80. And we screened 12,000 people, about 30,000 screens were done, 600 cancers detected, and found that there was a lot more cancers per screening round for older people, so 60% more cancers. So that age group is a very fertile ground for detecting cancers. And those cancers were early stage, 80% were stage 1 to 2. Most got early curative intent treatment. A bit more of a difference opens up when you limit to surgical treatment itself, with 41% of the older group getting to surgery, which is the gold standard curative treatment, compared to 58% in the younger group. And how did this pan out? So these are, on the left is everybody, all ages, split up with blue being the older group and red being the younger group. All stages of lung cancer in there too. And there is a bit of a survival difference. So at the end of 4 years, 56% of the older group were alive and 66% of the younger group. But still more than half of the older group were alive, which is encouraging. And then on the right, if we just look at people who got surgical treatment, that survival difference disappears. So the older group do just as well as the younger group. And even if we chop it different ways, looking at different subgroups, even just early stage cancers or curative intent treatment, older people do worse, but it's only when we limit to the surgical group that they do as well as younger people. So what do we take from this? There are plenty of cancers going around between 75 and 80 that we can detect through screening. All-cause mortality was a bit higher in the older group in relative terms, but in absolute terms, they still did relatively comparably. And that's if you include all lung cancer stages. But if you just limit to people who got surgery, the older group did just as well as the younger group. And I think this raises the question as to whether there's potential to extend the upper age limit, particularly if we're selective about who we screen. If we can find people who are more fit, more likely to get to surgery, then that would increase the benefit of screening, the cost effectiveness, and avoid harm. So we want to kind of make more equitable screening services to reach people of different ages based on ability to benefit from screening, rather than just sticking with kind of crude age ranges. Thanks for listening. This is the team that worked on this with me.
Thank you very much, Dr. Goodley. I'm looking at Chris, whether Dr. Nanbi has shown up. No? No. So apologies for that. So our final presentation will be given by Dr. Shani Shilo. As I mentioned in my introduction, IASLC is one of the very few organizations that includes patients in their briefings. We have been doing this for years, so it's my privilege to introduce Dr. Shani Shilo, again from the Israel Lung Cancer Foundation. Dr. Shani Shilo is DMD, PhD, and an R&D researcher whose husband was diagnosed in July 2011 with non-small cell lung adenocarcinoma at the age of only 43. She brings a unique international perspective as an IASLC patient research advocate who has been a caregiver also of a patient coping with lung cancer for almost 15 years. Dr. Shilo, we are looking forward to your presentation.
Thank you so much. And you know, I was a professional like you doing other things, and lung cancer happened to us. It happened to my husband. And you can imagine how devastating it is to be diagnosed with stage 4 lung cancer. My husband was 43, I was 39. Don't calculate my age, please, today. And my kids were 6 and 9. So the world collapsed on us. And you know, I knew back then that it was 2011, and because I have a background, I knew that he will die, you know, maximum in 1 year. And so I had to do whatever I can, you know, to save him. And I always say he, you know, like any husband, of course, he was annoying sometimes, but, you know, he was my best friend. So we went on this journey, and in this journey, eventually he was on some very new things. He was on a study of Foundation One medicine where he was found to be ALK positive. And he went through 5 TKIs. And through our struggle, I understood that there are unmet needs. So in 2014, I left my job and everything, and I established the Israeli Lung Cancer Foundation. So since then, we represent thousands of families and caregivers. This plenary was very interesting, and I want to remind us all, like you said, that behind every dot on these graphs and every data point, there are patients. And as I say many times, it's not only patients, there's a patient, but next to the patient, there's a caregiver and more people who live in the household of the patient. So when we treat the patient and help the patient, it's not only the patient, it's the caregiver, it's everybody who lives together. And what I saw in these studies, that there's a clear common thread, as they all ask, how can we deliver the right treatment at the right time in the right way to give patients not just longer life, but better life. And better life for the patient, like I said, is better life for the caregiver. So this is very important. And also what we saw here, even from the first study, which is the concurrent and consolidative Durvalumab versus consolidation, we saw that we can now today fine-tune all the regimens of treatments because we have more options, we know more and more, so we can check different kinds of things. And this is an important study because it showed us that more treatment is not always better, right? So this is very important. Another important thing that we've learned here, because lung cancer screening is being more and more approved all over the world, and this is, prevention and early detection is like the best thing we can do, right? Even with all the new treatments for stage 4 lung cancer, the best thing is to heal from lung cancer, right? So doing all of these screening programs, we saw here that if we give the patients a better treatment after surgery, then the recurrence rates are lower. So this is very needed. Another interesting article that was, trial that was presented here was the hypofractionated versus conventional fractionated radiotherapy. And I think one of the, even more meaningful than the results, thinking of me, taking my husband to the hospital for every treatment, going to the hospital for 3 weeks instead of 6 weeks. This is so important. This is so strong. This is a really, real important difference. So, and it has a lot of meanings, right? Because usually a patient does not go alone. Somebody has to come with him, and this somebody has to take a day off work, and somebody has to take care of the children, and et cetera, et cetera, et cetera. So, so this is very an advantage for everybody. Also, things that we saw here were all kinds of procedures like VATS instead of open lobectomy that really benefit, again, the patient and the caregiver because this is less invasive. Recovery will be fast and easier and safer, and this is the future. An interesting study that was here regarding the STAS really got me thinking because should patients and caregivers know about STAS? Like, if a patient has a STAS result, should we expose this to the family? Because this is a bad prognostic factor. And for me, because I knew the situation in lung cancer, because I knew my husband is going to die, it drove me to look for anything possible. It drove me to do the impossible. But the common patient or caregiver, should they know about stuff like that? This is maybe interesting, maybe to answer later. What do you guys think? Because I'm not sure even as a patient advocate, patients and families need to know things, right? But knowing that you have a negative prognostic factor, it's very difficult and people need hope. So this is something interesting to learn from you. And the last thing, of course, regarding screening with age, with 75 to 80. So what is age today, right? It's not the number, it's how are you doing? And this is what we saw here, that if you are doing okay and can go through surgery, then you'll benefit from it. So maybe we need to go towards screening programs in the later ages that are not dependent on age but on performance. Okay, so with this, let's just conclude that science is moving forward, and every trial, whether it shows benefit or not, brings us closer to more personalized, humane, and effective care. I want to say that we are with gratitude for the researchers, clinicians, and all of you who make these studies possible. As a patient advocate, I hear the voices behind the data. And what you did here is you give us life. And the message is clear. Progress in lung cancer isn't only about discovering new medicines, it's about using the tools we have in smarter, kinder, and more personalized ways. Because of you and thanks to you, my husband was alive for 11 years, and I thank you for that. Thank you.
Thank you, Dr. Schilo, for sharing your personal experience. Does not always be easy for you. Yeah. And regarding your question, I welcome the panel to answer. When I started as a student, I remember the professor of pulmonology when a patient asked, do I have cancer? And he said, no, it's not black, it's not white, it's something in between. And I think we have learned a long way that we should be quite honest to our patients and really say you have a cancer. Whether to say all negative prognostic factors, I'm not quite sure we should do it, but when the patient asks for it, we have to give some idea of prognosis, but also provide a solution, I think, that you say you have that negative prognostic factor, but we have the opportunity or the possibility or to treat you that or that way with the newer. I don't know whether someone of the panel will respond to that. Or in the audience. Yeah, Dr. Varlotto?
I'll respond. I think you're right. We have to really, be honest with the patients, but we also have to tell them what they want to know. Some people do not want to know exclusively, and I always give them that chance or opportunity. I'm a radiation oncologist, so I'm always looking at films with them. Do you want to see us as a big question?
Yeah, that's right.
That's right? Okay. I'm sorry. I'd have to say that I agree for the most part. We have to tell the patients and their families what they want to know. And when, in some instances, they do not want to know. As a radiation oncologist, I'm always looking at films, and I ask them up front, do you want to see your films? Do you want to see what your disease looks like? What goes off in my mind when I see your disease, your location, how it'll affect treatment and outcomes. So those are, those are the questions that I go over with families, and it has to be individualized. But we have to be honest, as you were saying.
Yeah, okay. Other comments or no? Oh, yeah, please.
So yeah, in terms of giving information to patients, I think sometimes where doctors can be too confident in predicting how the future will go. Because in any study, there's a range of people, a range of outcomes, and we're wary to give people a number to fixate on if they're likely to be different from that. So, so there are reasons why we might hesitate to give all the information that we have, because we're not sure what it means and how much it will help their care. But it's a good point, and we need to be mindful, and hopefully patients feel empowered to ask questions that they're interested in.
It's the third button, yeah.
This one? Yeah, just to, oh no, I forgot what I wanted to say, just a second. Yeah, well, once I thought that maybe we should do something, because this is also regarding communication between, the doctors and the patients, is that maybe when a new family comes, a new patient or caregiver, the people who interact with the doctor, maybe we should have like a questionnaire for them to understand how much they want to know, to understand, because there are families and patients that want, the bold truth, that it's very important, and there are ones that you say, no. But what happens today that you as a doctor, but also me as a patient advocate, when I speak to patients and families, in your mind, your mind makes the calculation of what kind of person this is and how much they want to hear. Right? I mean, this is something I think we do automatically when we automatically analyze the personality of who is in front of us. And maybe we're wrong sometimes. So maybe we need to do something regarding this to understand who is the person, what's the personality of the family, and adjust, the communication according to that.
I'd just like to make another comment on that, just from the pathology side. So in the United States, there's something called the Cures Act, where the pathology reports are immediately released to the patient record. So they oftentimes see the pathology report before the clinician does. And this has created some issues, as you can imagine. So I'd love some perspective on that, because when we're putting together the pathology report, obviously we're putting it together so the clinician can make the best decisions for the patient. So we do have all of these prognostic features and things like that in the report, and then the patient will see it in their chart often before the clinician does. And I would just be curious from the clinical team how that's impacted them, how you would feel about that.
And of course, today you can just do AI and it will give you, like, it will explain to you what you have, right?
And just to add on, I think echoing the thoracic surgical team at the Brompton, we are aware of terminologies and trying to make patients have better understanding of their condition, of their mutation, molecular profile. And what we do is to basically invest a lot of effort to develop patient education materials, which is, like you see, screened by AI, and basically to synthesize all the information to them. So I think definitely looking into those kind of patient education tools is super crucial.
Yeah, in our center, the pathology reports are not made available to the patients, but the radiological reports are made available. And sometimes when there's a follow-up, and usually the radiologist says in his summary, malignancy cannot be excluded. And we have a lot of problems with that, because the patient sees the evening of his CT scan and immediately phones, what does it mean, before we have seen the images or discussed the images ourselves. So it's good to inform the patients, but sometimes you need some kind of discussion. Are there any questions from the audience? I cannot see you very well, but...
There are thousands of people here.
Yeah, I can see them, even the audience. Okay. So I think that we can then conclude this session. I would like to thank all the presenters for their excellent contributions to the Presidential Symposium. And I would like to thank you all for attending this press briefing, including those who access the briefing online, as well those who will review the briefing on our YouTube channel. And we are happy then to answer all your questions. Thank you for coming over.